chapter 13, vital signs and monitoring devices. We're going over how to take vital signs, how to monitor patients. We've already done a little bit of this in class, but this will be a good refresher and review. We'll go into some things more in depth. Okay. So gathering the vital signs. The importance of vital signs is the outward sign of what's happening inside the body. So what's happening, what we can see from outside to give us some clues as to what's actually happening inside. We're going to identify important conditions or trends. Trends are ongoing things that we can kind of trend vital signs. So if a pulse rate starts to elevate, we're going to be able to monitor that, watch it get larger. It kind of gives us some clues as to what's going on with the patient. We gather these on every patient. Critical patients, we get vital signs every 5 minutes. Non-criticals are about every 15. We also, one of the vital signs is the patient's pain level. So that's going to be something we're going to look at as well. So we're going to be trending pain levels. Patient severity and treatment priorities may prevent acquisition. If we're stuck on the ABCs, airway, breathing, and circulation, we may never make it to the vital signs because they're farther down in our assessment pattern. So we have to focus on airway, breathing, and circulation at all times. So, vital signs. So what are vital signs? First and foremost, pulse, respiration, skin color, temperature, and condition. The pupils. Pupils are one that a lot of people forget. Assessing the patient's pupils is extremely important and can give you a variety of clues as to the patient's condition. Dilated pupils, constricted pupils, are they reactive to light? Those things matter. We tend to overlook pupils. As you get better at your job and get better at being an EMT, you'll start to pay attention to every person's pupils. I can walk up to somebody and know if they're dehydrated a lot of times, or if they drink a lot of caffeine, or sometimes if they're on drugs. So I pay attention to pupils very closely, and you should as well. Blood pressure. Blood pressure is another very important vital sign. We get it on pretty much every patient. And once again, like we've talked about, if you don't know what you're hearing, then don't report it. Don't just make up a number. That can be hugely detrimental. So if you're not sure, just tell your partner you're not sure, and we'll go from there. So, baseline vital signs. Baseline is the first vital sign obtained. It's the first set, right? We're going to get that first set of vital signs that kind of gives us an idea of where we're at and where we're going. Then when repeat vital signs, we get more information. We can start trending some data. Remember, some of our patients we may have for an hour or more, depending on where you work. And so it's very important to kind of trend those vital signs out. Pulse, palpable pulse of the heart beating. You can actually feel it causing blood to move through the arteries in waves. So we have our carotid pulse, our radial pulse. We do a brachial pulse on infants. It just depends on the person. Okay? Be felt by placing the fingertip over the artery where it lies close to the body's surface and crosses over the bone. So at the radial location, we go on the thumb side, kind of find the thumb side just there in the middle. Never use your thumb because it has its own pulse, and then push down like that, and you can feel a nice strong pulse. Okay, here you can see the EMT is doing this. Once again, he's using his index finger right there, thumb side of the wrist, and you can apply some pretty decent pressure. We're going to count for 30 seconds and multiply by 2, and that'll give us a good pulse rate. We can count to a minute, but who wants to sit there and hold it for a minute? That's ridiculous. We don't have time for that. So most people count the pulse out for 30 seconds and multiply by 2. Pulse rate is the number of beats per minute. Our normal pulse rate is 60 to 100, right? So right now, I'll use my little Apple Watch, make sure it's right. Yeah, I'm at about 64 beats per minute. So that's pretty close to where I normally sit, okay? I've also gotten a lot more used to pulses, so I can take them a little bit faster. I kind of have that, yeah, that's pretty normal. That's right where I should be. I'm probably around 70 because I'm up and talking, that kind of thing. But to be accurate, we need to actually feel for 30 seconds and multiply by 2. Tachycardia is a rate over 100 beats per minute, and it's going to be a rapid pulse rate. So if you feel somebody right off the bat and you're like, oh, that feels really fast, it's probably on the tachycardia side. Bradycardia is a rate below 60 and is considered slow, okay? So tachy is fast, brady is slow. A pulse rate above 120 beats per minute or below 50 beats per minute is considered a serious finding. So above 120 or below 50 can be considered serious. During an emergency, it is not unusual for pulse rates to be temporarily between 100 and 140 beats per minute. So think about it. People get excited. You know, if you're in a car accident, wham! It doesn't mean that you're going to be sitting there at 60 beats per minute or 70 beats per minute. You're probably going to be at 120, 130, 140. When I go run, I'm way above 140. That doesn't mean I'm dying. It means that we got to reassess and trend that out to see how long that lasts. So what normal situations might occur for a heart rate to be outside of the normal range? We talked about that. Car accidents, going out for a run, working out, those kind of things. So pulse quality. There's two factors that determine pulse quality. There's rhythm. So is it regular? Does it hit every steady so often? Okay. Reflex regularity. Regular when the intervals between beats are constant. So like I said, if it's doing a constant beating, it feels pretty regular. If it's irregular, it's when intervals are not consistent. So, you know, it's like. So if it's low, that's an irregular pulse rate, right? It should be nice and steady. So force, pressure of the pulse wave. So is it weak? Is it thready? Does it feel like it's kind of coming in and out, like you can feel it every time, but it's just barely there? Or is it strong and bounding? We typically use the radial pulse location for patients who are alert and oriented. We go to the radial. We kind of jump to the carotid for unresponsive patients. Because we may not be able to feel a radial pulse on a patient that is hypotensive, so we may jump straight to the carotid. Okay, used in patients on 1 year and older, the wrist pulse, that's the radial, found by placing first 3 fingers on the thumb side of the patient's wrist, just above the crease, and it's going to be just like that. I typically use 2, and it's just on the thumb side. Okay, and there he is doing that. Good job again. Brachial, used in patients 1 year old or younger. It's an upper arm pulse. Okay, and here you can see them find the brachial. A lot harder to find in adults, but in kids you can find it right there. You palpating brachial pulse in infants. Carotid, felt among the large carotid artery on either side of the neck. So if you find your midline here where your jugular is, you're going to come straight to the side of that, push back and up a little bit, and you can find your pulse. Okay, same on this side. Once again, I'm using 2 fingers. I'm not using my thumb. Just come right in there. Okay, it's below the jawbone. Find your thyroid. Come off to the side of it, and you'll be able to feel a nice pulse. So assessing pulse, we're going to have constant pulsations for 30 seconds, and then we're going to multiply by 2. We talked about that. We're going to look for rate, rhythm, and force. Okay. If it's not feeling normal, we might need to do that for a full 60 seconds, especially if it's very irregular, just to make sure we have a good judgment. Okay. So respiration, like we talked about the other day, means breathing in and out. Okay. So we're going to include both the rate and the quality. So if I'm breathing right now, I'm talking, my rate may be up a little bit. My quality is fine though. You don't hear me wheezing or gasping for air. I'm breathing pretty normally. The number of breaths the patient takes in is the respiratory rate. That's the number of breaths per minute, right? So our normal rate, 12 to 20 for most adults. It's either normal, rapid, or slow, okay? There it is, 12 to 20 is our normal at rest. If you're a healthy adult, you're probably going to be closer to the 12 range. If you're overweight, you're probably going to be closer to 20. Age, sex, size, physical condition, emotional state, while you're doing this test are all going to matter. So if I just got told that my girlfriend broke up with me, I may be very upset and bawling, right? My respiratory rate's going to be up. It's like when you try to get it on an infant and they're crying, their respiratory rate's through the roof. Doesn't make much sense, okay? So rates above 24 breaths per minute or below 8 breaths per minute are potentially serious. And we say once again potentially because depending on the situation, they may not actually be that serious. So there's 4 categories of quality. There's normal, shallow, labored, and noisy, okay? Shallow, they're not getting much in. Labored, you're going to be able to hear them breathing. They're having a difficult time. They're really using accessory muscles, drawing in, maybe hunching over as they're doing it. Noisy, obviously that makes sense. It makes a lot of noise, okay? So skin, that's also one of the vital signs we're looking at. It's an outward sign that we can take in. They have color, temperature, and condition of the skin. It provides valuable information regarding circulation. So if they're pale and cool and clammy, we know they're probably sick. They might be shocky, okay? If they have warm, dry skin, they may be overheated. We have to look at all that stuff to make a good impression of what we're doing. So color, best place to assess color is in the nail beds, the inside of the cheek, or the inside of the lower eyelids, okay? Abnormal skin colors would be pale, cyanotic. Cyanotic is kind of a bluish, grayish color. A lot of times you'll see it around the lips. Flush red or jaundiced, when their skin starts to turn a yellowish color. Those are all abnormal skin color signs. Temperature, we're going to feel the patient's skin with the back of our hand. Once again, we're going to touch our patients. We're going to do full assessments by touching our patients. If the skin feels normal, warm, hot, or cold, right? Some of our patients touch are very hot. We know they probably have an infection. They might be septic. Okay? Some patients are cold. They're going to need some rewarming. So there you go. There's a good view of a paramedic. Still has his glove on, maybe rolled down just a little bit, but he's using the back of his hand to assess skin temperature. And then that initial skin temperature might throw us, okay, we really need to get a temperature, an oral temperature on this patient here soon. So for kids under 6 years old, we also need to evaluate capillary refill, okay? We're going to press on the nail bed on the top of one hand or foot and release. I don't know if you guys are going to be able to see this, but if I press and release, yeah, you're not going to be able to see it. You count the number of seconds for the blood for it to go back to normal color, okay? It should be less than 2 seconds. So most patients, it's going to be less than 2 seconds when you do that push for it to come back to normal color. Longer than 2 seconds can mean a sign of poor circulation. They might be deoxygenating. We may need to treat them for shock. Okay? Pupils. One of my most, I just can't say it enough, you should definitely be assessing patients' pupils. Okay? So we got to look at the black center of the eye. In a dim environment, the pupil will dilate. In a bright environment, the pupil will constrict. I love to use pupils around us to assess. So if I think your pupils are messed up for some reason, I'm going to look at you over here. I'm going to kind of compare your pupils. And theoretically, in the same lighting environment, they should be pretty close. And if you're still real dilated, I know that something's wrong. You may be dehydrated. You may have drank a bunch of caffeine. I'm not sure. If you're really constricted, I'm thinking maybe you're on opiates. Maybe you have some pain medications that you're taking for whatever reason. So we have to monitor all those things. So we're going to note the baseline size, okay? I'm going to note what your pupil should look like. We're going to cover one eye and shine a light into the other eye, and then we're going to repeat, right? And we're going to see if those pupils are adjusting and reacting appropriately to light. So there you have your EMT once again. Shine a light in, he's seeing if these are equal bilaterally. We're looking for size, quality, and reactivity, okay? All three of those things. So this is hard to see probably from there, but if you're following along in your books or on the PowerPoint, we've got constricted. They're kind of pinpoint. They look like maybe a little bit bigger than a pin on a pen, the tip of a pen. You have dilated. They're like the size of maybe the end of my pinky. And then unequal, one's dilated, one's constricted. This is really bad. Unequal pupils, unless you're born with it, which is like 1% of the population or less, probably means you have a head injury, okay? So unequal pupils can be a sign of the influence of a topical drug, like one placed directly in the eye, such as an eye drop, or of a head or eye injury. So this guy, you can see, is one normal size pupil and one pupil is severely dilated. Blood pressure. Blood pressure is the force of blood against the walls of the blood vessels. Normal blood pressure, your systolic, no greater than 120, diastolic, no greater than 80. I will tell you, a lot of people run, a little bit above 120 or a little bit above 80. It's not the end of the world. Change can indicate something very significant. So if I'm normally 120 over 80, just real normal, and the next day you see me, I say I'm not feeling very good, you check my pressure, and I'm 102 over 70, something's wrong, right? That's a big change. That's something we need to pay attention to. So it's measured with a sphygmomanometer. Yeah, try to say that 10 times fast. And a stethoscope. The cuff should cover 2/3 of the upper arm, elbow to shoulder. 2/3 of the upper arm, elbow to shoulder. There it is. And it's positioned correctly. These blood pressure cuffs have artery markers that should be trying to go kind of in line with your arteries, okay? So we want to also make sure that the cuff lines up with the artery as best as possible, and then it's the right size cuff for the patient. I'm going to wrap the cuff around the patient's upper arm. The lower edge of the cuff should be placed about 1 inch above the crease of the elbow. The center of the bladder placed over the brachial artery, okay? We want to prepare the patient, position the cuff and stethoscope, palpate the brachial artery at a crease of elbow. We're going to position the diaphragm and the stethoscope directly over the brachial pulse or medial anterior elbow. See, a lot of people do this wrong, right? They think, first of all, these always go pointing forward. Don't put them towards the back of your head. They point forward. So get them in your ears. Make sure they're pointing forward. Make sure when you hold it, you're kind of on either side of it. Place it down and put some firmness on that, man. We're not just touching it. We're not doing it like this so you can get your pulse of your thumb. Grab it, use your 2-finger technique, and then put some decent pressure down so you can actually hear it. There's a good picture of him holding that, trying to get a good pressure. So we're going to inflate the cuff. We're going to listen and inflate until the gauge reads about 30 millimeters higher than the point the pulse sounded disappeared. I'll tell you, most of us just inflate that thing up to about 200 and we start releasing, okay? So we get the blood pressure cuff up to about 200, start releasing. If we immediately start hearing the whoosh, whoosh noise, we know that we have to go higher, okay? So we'll start releasing. We're going to release slowly air from the cuff. When you hear the first of these sounds, we're going to note the reading of the gauge. When you hear the first whoosh noise, you're going to note that as your systolic blood pressure. We're going to continue to deflate the cuff, and when the sound turns to dull, muffled thuds, the reading on the gauge is the diastolic pressure. So when you're having difficulty hearing it, starting to become more just barely there, that's your diastolic, okay? We're going to record those measurements. So you can also do it by palpation. So let's say you have your stethoscope, you don't have a stethoscope on you and you just have your fingers and your blood pressure cuff, okay? You're going to inflate the cuff and obtain and record a systolic pressure. We're going to slowly deflate the cuff and note the reading when the radial pulse returns, okay? So we're going to have our finger there. We're going to note when we feel that pulse come back, okay? Pediatric is difficult to attain on infants, children younger than 3 years of age. It's a little bit harder. It's more useful information about the condition of an infant or a very young child comes from observing. We're going to look at our patient, okay? It's better to watch your patient and see them react. We do like to get blood pressures just if we can, especially on heart patients or sick kids. That may be important, but it's better to watch your patient, assess that skin color and circulation to see how they're doing. Once again, blood pressure monitor. We're going to position the cuff, same positioning. We're going to inflate the cuff. It's going to slowly deflate and we'll record the pressures. If you're on a monitor, it does it all for you. I will tell you not to trust your monitor. You need to be listening to manual blood pressures. Otherwise, you're going to get tripped up at some point. Also, if you put the wrong size cuff on the patient, you will get tripped up. You have to get the right size cuff. If it is super big and it's wrapping around their arm twice, it is too big, it's going to show low pressure. If it's barely Velcroing, it's going to show a really high pressure, and you're going to get your medic or yourself confused on what the right thing to do for that patient is. So make sure you have the right size cuff on the right patient. Temperature. There's a narrow range of temperature, allows chemical reactions and other activities to take place inside the body. Our core temperature reflects the level of heat inside our trunk, okay? So we want to get temperatures. A lot of people forget about these, and it can be a good indicator of what's going on with our patient. So a normal temperature depends on the time of day, activity level, age, and where it's measured. Your oral temperature is not going to be the exact same as your axillary temperature, okay? So we have to know these. So here you see your EMT out there getting electronic thermometer under the tongue, getting an oral reading. So the measurement, okay, so that's it for temperature. Just make sure you're getting temperatures on these folks. They need to have that monitored. You don't know if they have some severe infection. Sometimes we'll feel them and not realize how hot they are because we may be worked up. We may be doing other things. Oxygen saturation. It's the measurement of proportion of oxygen attached to hemoglobin. It's measured with a pulse ox. It is not their O2 stat, it's their oxygen saturation or O2 saturation. O2 sat, not stat. Stat means now, sat means saturation. Okay? Protocol depends on the institution, generally includes all patients complaining of respiratory problems. We get an O2 saturation on everyone. Everyone gets their pulse, blood pressure, and oxygen saturation checked automatically. We do it on everybody. So there is a portable pulse ox. It's a bigger one. It says 98%, which is good because our goal is 94 to 100. 94 to 100 is perfect. Or 95 to 100 might be what your book says. Either one. That's correct. So this is saying 96 to 100. So listen to this. 96 to 100. Mild hypoxia is 91 to 95. Significant or moderate hypoxia is 86 to 90. Severe hypoxia is 85 or less. Okay? Pay attention to these numbers. These may be important. 85% or less severe hypoxia. Moderate hypoxia is 86 to 90. 91 to 95 is mild hypoxia. So the accuracy, how accurate are our SpO2 monitors? Okay? They depend on several things. If the patient's shocky or hypothermic, if they're very cold, we're not going to get a good reading. Carbon monoxide binds just like oxygen does. So we can't tell when we're doing our SpO2, we can't actually see that. It's going to show up as perfectly good, even though that may all be bound CO. Some types of poisoning, excessive movement, nail polish can block it if they're anemic. So these aren't the most detailed, they aren't the most accurate readings, but they are beneficial. Blood glucose. We're going to talk about more of this in class. We're going to do some blood sugar checks for fun in class. Everybody can poke each other. It measures the quantity of glucose in the bloodstream and can help identify some diabetic emergencies. So we'll be doing this at some point. Many EMS systems allow EMTs to use glucometers. We do allow our EMTs to use glucometers here at JCAT. So, using a glucometer, we need permission from a medical director or a local protocol. It's required to perform glucose monitoring using a glucose meter. Monitors must be calibrated and stored according to the manufacturer's recommendations. First, we prepare the device, strip, and lancet. Second, we're going to cleanse the patient's finger with an alcohol wipe. Third, we're going to perform a finger stick with a lancet. We're going to poke their finger. We try to go kind of on the side. It's helpful. And then you're going to kind of, it doesn't say this, but you're going to want to milk the finger, especially if they have bad circulation. You kind of want to push that blood up into the finger after you poke it to get it to bleed out. Sometimes it doesn't want to bleed very much. We're going to apply blood to the test strip, and then we're going to use the glucose meter to analyze the sample and provide a reading, okay? So we'll get that little bit of blood on the strip, and it'll take it in. We'll be able to analyze that and see what their sugar is. Normal levels, usually at least 60 to 80, but no more than 120 to 140. So 60 to 140 is kind of our range of normal. If it's above 140, they're probably diabetic. If it's below 60, they're probably hypoglycemic. So on pediatrics, age is one of the most important factors determining normal range. Infants and children have faster pulse and respiratory rates and lower blood pressure. So peds have all different normals than what we're used to, okay? They're going to run with blood pressures in the 90s or, maybe some in the high 80s depending on age, right? I'll let you guys watch this at home. You can watch that at home. All right, interview. Just to make sure everybody's got this. You're going to gain a great deal of information about a patient's condition by taking vital signs. It's imperative that we get good trends on these patients. We should really, anytime we're transporting a patient, we need at least 2 sets of vital signs. There's no reason why we should not even get any kind of trend built. 1 set of vital signs is just a glimpse of time, okay? We need at least 2. On refusals, that's a little different, and it's going to be agency dependent. We only require one set of vital signs on our refusals. We've got to be familiar with the ranges, what's normal, okay? We've got to be familiar with trends and how often to take vital signs on critical patients. These things are important. How often you can repeat will depend on the patient's condition. At least every 15 minutes for stable patients, at least every 5 minutes for unstable. At least is the base key word there. So if you have a test question that says something about how often you should take vital signs, it should be at least every 5 for critical, at least every 15 for stable. If there's time to take vital signs, you should be taking them, okay? Make sure you know what's going on with your patient. Airway, breathing, circulation first. Make sure we're treating life threats. Then we can monitor our vital signs. Consider whether abnormal vital signs are a result of an illness or injury or if it's something else. So my pulse rate may be higher now than it was earlier because I've been standing up talking for this long, okay? So it may not still be 70 or 72. It may have bounced up a good little bit because I've been standing up, moving around. It's going to be the same thing with the patients, although mine's still 72. So, remember questions to consider. Name the vital signs. Explain why vital signs should be taken more than once. You guys should know this stuff for your future tests. How much time should we take looking for a pulse if the radial pulse is absent or weak? Okay. How long do we ever spend looking for a pulse? Okay. And if they're unconscious, we should be going to a carotid. If you have a blood pressure monitor that gives you a crazy reading, just take another one, okay? If one of your readings, if you had several trending readings that are normal and then there's 170 over 50, that's probably not an accurate reading. How can you get an accurate pulse ox on a patient with thick artificial nails? You might have to stick it to their forehead or their earlobe, but you may not be able to use their fingers, or you can turn it sideways sometimes. You can get it on the finger sideways. So sometimes the patient's heart rate will be really fast, like above 200, it's saying. What kind of, why would they have a very weak pulse? If their heart's beating super fast, why would they have a very weak pulse? Think about that. If the heart's beating so fast it doesn't have time to fill, it's just going, that blood can never really get in there. And so it's going crazy. It can't fill and then push it out. It's just push it, and all it's doing is just little tiny squirts. So you're not going to have a good radial pulse, even though it's beating 200 times a minute. You're not going to have a good radial pulse because it's just squirting out. Instead of getting a full and then pushing and getting a full push out, it's just squirting little spurts. So that's why if you have a really, really fast pulse, if it's too fast, you're not going to have good blood flow. Okay, that's chapter 13. I hope that helps you guys at home because we do have an accelerated course. If you feel free, if you're watching this, hopefully it helps you do better on chapter 13 test.